oltre 30.000. Questo è il numero dei ricercatori italiani che lavorano fuori dal nostro paese secondo le stime del Ministero degli Esteri. Negli Stati Uniti siete circa 15.000, 6.100 nel Regno Unito, 4.000 in Francia, ma siete ovunque. Un piccolo manipolo in Corea e poi in Argentina, Sudafrica, India. Non c'è un continente in cui la scienza non progredisca anche grazie ai ricercatori italiani. E questo è naturalmente motivo d'orgoglio, ma non è una novità, perché la ricerca per sua natura è internazionale, non conosce confini. Da sempre, oltre alle idee, hanno viaggiato le persone, a cominciare dal genio per eccellenza, Leonardo, che nel 1517 si trasferisce in Francia, dove continuerà i suoi studi di ingegneria, anatomia e sulla natura. Ma se la scienza antica ha in comune con quella moderna curiosità e passione, ben altri sono i mezzi di cui disponiamo oggi, mezzi tecnici naturalmente, ma soprattutto il più potente di tutti, l'unione delle capacità mentali. Perché se la scienza antica era caratterizzata da geni solitari, quella moderna trae la sua forza dalle grandi collaborazioni, come quelle che sostengono la fisica delle particelle al CERN o la grande ricerca spaziale coordinata dalle agenzie internazionali, fino alle piccole collaborazioni fra ricercatori che si stabiliscono quasi spontaneamente per indagare problemi specifici, come alcuni di quelli che hanno a che fare con l'epidemia che stiamo vivendo. I ricercatori italiani all'estero sono allo stesso tempo parte della comunità scientifica del nostro paese, di quella del paese che li ospita e della comunità internazionale largamente intesa. Ora, per il bene di tutti noi che dalla ricerca ci aspettiamo conoscenza e soluzioni, è importante che queste tre identità convivano senza affievolirsi. È fondamentale che la nostra nazionalità continui a essere una risorsa per chi fa ricerca all'estero ed è cruciale che la grande qualità dei ricercatori italiani sia percepita all'estero come la naturale conseguenza di un'eccellenza scientifica che non venga fraintesa per una somma di talenti individuali, cosa che sarebbe inverosimile vista la vostra ubiqua e numerosa presenza. Per tutto questo c'è l'impegno degli addetti scientifici e della rete diplomatico-consolare, c'è il supporto di Innovitalia, il portale della diplomazia scientifica italiana, ma soprattutto per il mantenimento di un'identità scientifica italiana noi cittadini contiamo sulla vostra collaborazione attiva, sulle vostre intelligenze e sul vostro impegno.
Welcome. Thank you very much for participating in this webinar. My name is Veronica Manson, and I'm the director of the Italian Cultural Institute and your host for this afternoon. I would like to pass the floor now to Consul General Eugenio Zabrze for his welcome message. Consul, floor.
It's with great pleasure that I address you today on the occasion of the 4th edition of the Day of Italian Research in the World. The celebration of Italian research worldwide is an annual event organized by the Italian Ministry of Foreign Affairs and International Cooperation through its networks of embassies, consulate generals, consulates, and Italian cultural institutes. It takes place every year on April 15th, the anniversary of the birth of the Italian genius, Leonardo da Vinci. Today's talk has been organized by the Consulate General of Italy in Toronto in collaboration with the Istituto Italiano di Cultura in Toronto. Beyond its cultural heritage, Italy is at the frontier of many crucial medical advancements, as well as developments in the field of technology applied to the medical sciences. The Day of Italian Research is celebrated in 78 countries around the world, with more than 100 events involving very famous Italian scientists, researchers, and representatives of national technology companies, all points of excellence that bear witness to the distinction of Italy's research and innovation worldwide. To mark this celebration in Toronto, we have the honor today to have with us Professor Gianluigi Bisleri, a researcher, cardiovascular surgeon at the St. Michael Hospital in Toronto, and associate professor in the division of cardiac surgery at the University of Toronto. I'd like to thank Professor Bisleri for sharing with us today the experience of the latest developments in the field of many invasive cardiothoracic best practices. I would like to thank also Veronica Manson, the director of the Istituto Italiano di Cultura in Toronto, for organizing this webinar. And last but not least, I would like to thank all of you. I would like to thank the public for attending this event, and from Toronto, from all Canada, as well as Italy. Thank you very much for your attendance.
Thank you very much, Consul General, and welcome to Dr. Gianluigi Bisleri. Thank you for being with us today. My name is Veronica Manson, as I was saying, and I'll be your host this afternoon. Just a note for our viewers that during Dr. Bisleri's presentation, there will be some images of procedures and some anatomy, so viewer discretion is advised. Now, Dr. Bisleri, Professor Bisleri, you have a very interesting curriculum that brought you from your native Brescia, Italy, to Poland, and then the UK, and finally Canada. You are currently, as the consul was saying, cardiovascular surgeon at St. Michael's Hospital and associate professor in the division of cardiac surgery at the University of Toronto. You graduated from the University of Brescia Medical School, and following a residency in cardiac surgery at the University of Padua, you completed a research fellowship in arrhythmia and minimally invasive robotic surgery at the Presbyterian Medical Center in New York, as well as clinical fellowships in the Silesian Centre for Heart Diseases in Zabrze, Poland, and in Essex Cardiothoracic Center in Basildon, UK. So from 2006 to 2016, you worked as a cardiac surgeon at the University of Brescia, where you became associate professor of surgery, as well as co-director of the arrhythmia program and director of the aortic surgery program. From 2016 to 2020, you joined Queen's University and the Kingston Health Science Center when you moved to Canada, where you contributed to the development of novel approaches for minimally invasive cardiac surgery and the treatment of cardiac arrhythmia. And now, just last January, you joined the team of at the cardiac surgery division at St. Michael's Hospital. So really, you have an impressive national and international career. And my first question, I would like to start this webinar with a question on the latest developments of minimally invasive treatment of heart disease and arrhythmia. Thank you, Professor Bisleri.
Thanks very much, Director Manson. I'm extremely honored and pleased to be here today, obviously, for this extremely important event, international event, and as an example of how Italy can significantly contribute to research advancements. And for me, so again, thanks to the Council, thanks to Institute you're directing, and again, thanks to the public for listening to this conversation about the advances that we are actually strongly bringing forward in the management of heart disease. I would like to share some slides that can help outline the work that is currently undergoing. And I find this being extremely exciting in terms of the potential areas that we are able to address. The work that has been done is specifically in the institution that I recently joined is extremely innovative. But in a way, I'm also very happy that I'm bringing some knowledge and techniques that have been developed during my work in Italy. So it's really a contribution of our Italian background also here in Canada. And the first thing I wanted to somehow bring to the public is that every time there is the conversation about cardiac surgery, obviously the most important incision, most important approach has been historically a pretty large incision in the front of the chest, which is something extremely helpful in order to perform the vast majority of cardiac surgical operations. But it's also very concerning for patients. I have to say that in my professional experience, most of the times, many patients are actually concerned for the psychological effect that also such incision in the front of the chest can really lead. And over the last several years, we have progressively consolidated a series of approaches that are alternative to a big incision in the front. So, for example, we can also perform what we call a mini sternotomy, which means a smaller incision still on the front of the chest, or actually going through the side of the chest in a way that is called a mini thoracotomy. That means going through the ribs on the side of the chest, or eventually even performing a procedure which is completely endoscopic, which means that only tiny cameras and instruments are used without any actual visible scar, what we could label as a keyhole approach for surgery. And one thing that I would like actually to echo the initial introduction to the research day and about the fact that we need collaboration. Well, when we are talking about minimally invasive heart surgery, it's not only about the incision, but it's actually about a teamwork. And there is, of course, the surgeon performing the surgical procedure and obviously paying attention to perform the intervention through a smaller axis, but at the same time, we need the entire team. I often, when I'm starting these programs, I always make the analogy of a Formula One team where everyone has an extremely important role in order to win the race. And obviously for us, winning the race means having the patient going safely through the surgery and being able to have a fast recovery. So every step is extremely important. Now, when we're talking about the advances in heart surgery, I will try to give you a hopefully pretty broad overview of many advances that we have been able to bring to the table, from management of valve problems to management of coronary disease, or also irregular heart rhythm through a less invasive approach. And I'll start with this animation that shows roughly how our heart is obviously made, and it's composed of different sections, the upper and the lower chambers of the heart. And this is a valve where I would like to start this conversation from. It's called the mitral valve, and this is a valve that can often become diseased. And we are able to perform now procedures that are called as minimally invasive mitral surgery, which means that rather than opening the chest in the front, we are able to fix, repair, fix the valve through the side without any major impact and trauma to the patient. So there are two important aspects to what I'm trying to stress here. The fact that we can avoid replacing a valve. Many times when a valve is diseased, we need to take the valve out and put a prosthesis, an artificial valve in, but we're actually able now to use very complex techniques to repair and actually maintain the valve of the patient. This is an example of what happens in a very common problem called a prolapse for the mitral valve, which I'm sure many people in the audience may have heard about. I always, when I explain to patients, make the analogy of a parachute where either the sail or one of the strings have become too loose and the parachute is no longer working effectively. And this is exactly what happens here. You can see in the animation in red, blood that is supposed to move forward is actually going backwards, and thereby making the patient feel sick. typically short of breath. Now, we have historically tackled this problem using an approach in the front of the chest, which, as I mentioned before, it's an effective but invasive approach. And now we progressively moved to a less invasive approach using cameras and tiny instruments that allow us to minimize the trauma to the patient. We are still using the heart lung machine, which is a tool which is extremely important to control and support the heart and the lungs of the patient. And as you can see in the animation, we have very advanced techniques that are allowing us to literally reshape like a tailor. I think it fits very well with our tradition of being very good tailors as Italians. But for sure, this is a very now effective way to fix the valve without further aggression to the chest for treatment of such disease. And we actually have moved this even further by having what is called a transcatheter mitral valve repair, which means we not even stop the heart of the patient or open the heart. We do all this procedure using actually a catheter, which is a very, very important approach, not suitable for many patients, but in selected cases is an extremely effective technique, which basically allows us to treat by a single incision from the groin. So by making a small puncture, we then are able to advance these very sophisticated catheters. And as you can see and appreciate in the animation, we are literally able to grasp, we call technically clip. You can see the white part is a clip that is able to bring the two leaflets, the two parts of the valve together. And that allows us to repair the valve using a catheter, using really the least possible invasive approach. And I'm actually very proud to say that this technique is actually the transcatheter version of a surgical technique developed by an Italian surgeon, Professor Alfieri, who's been working in Milan. So again, another reason for being proud of our history and contribution to this field. And now we're also able to have strategies that are allowing us to replace mitral valves by using transcatheter techniques. So we have historically been opening, obviously, the heart of patients, and we routinely do so. But again, in high-risk selected cases, we are now able to use these very advanced tools that allow us to approach from the apex, from the top of the heart, with a small incision through the ribs. And then we're able to deliver this very complex device, which again is a transcatheter valve. And this valve basically can be implanted without any suture, without again opening the heart, and with minimal impact to patients. This is obviously a very evolving field. So as I mentioned before, and for most of my statements during this presentation, we are obviously limiting this to selected cases, but I'm very proud, especially to say that in my current institution, for example, we performed the first case in Canada, and we are really pioneering many of the procedures in general at an international level. We also treat another very common problem, which is called aortic valve disease. That means that one of the valves in the heart becomes too tight and doesn't open well. And we have now two options to treat that, both surgical and transcatheter. We can perform this operation using, again, a small incision in the front of the chest. And now, when we are treating this problem, which, as I mentioned, it's called aortic valve stenosis, it means that the valve, as displayed in the animation here, has become too thick and doesn't open well. We have available certain new techniques and new technologies like these valves that do not require any sutures to be placed, and we can very effectively and rapidly deploy. That means leave in situ these new valves that are really making the surgery extremely less invasive and fast. And to the point that we have become extremely also competent in actually doing this procedure using a catheter. Again, this procedure has been in the past 10 years limited to patients who were inoperable or very high risk for surgery. The bar is actually changing now also to patients who are, let's say, over the age of 80. Still, in many cases, surgery is the best option for patients, but again, in a very good percentage of patients, we are actually offering this option that allows really to completely avoid the surgical trauma and intervention. And as you can appreciate in the animation, it really allows us to navigate through the aorta backwards, again, from the groin into the native valve of the patient, and then very effectively deploy, so release a new valve inside the previous one without stopping the heart. And recently, we don't even have patients being asleep anymore. So it's a pretty outstanding advancement from the technology standpoint. Another problem that is often present in the population is called atrial fibrillation, and many, maybe even people in the audience could have heard about that. And atrial fibrillation is an irregular heart rhythm. Normally, as you can see in this animation, our heart has a very organized electrical and mechanical activity. So we have the upper chambers and the lower chambers of the heart, and there is a very precise sequence that is normally followed, and that makes possible for our heart to function in the best possible way. Atrial fibrillation is actually a problem, a disease, which affects the upper chamber of the heart, the atria, and they start beating in a very irregular fashion. I often explain this to patients as a sort of electrical storm, which means that everything is extremely confused and irregular. And unfortunately, then it transmits this irregularity also to the lower chambers of the heart, called the ventricles, where really the main pump of the heart lies. And that can obviously lead to many problems to patients, from feeling what we call palpitations, so feeling the heart beating irregularly, then having an increased risk of stroke, and even leading to potential heart failure. So it's definitely a harmful condition. So we have been treating atrial fibrillation initially with medications and then using catheters to perform an ablation. But we also have an option of a minimal invasive surgical ablation. And I'm, again, very, very happy to share that this is not something developed, let's say, very recently, but actually we have been pioneering this work. This is a publication that I formally did with my previous chief in Italy. And as you can see, is actually 15 years old. So we have been really in the field, innovating and pioneering. And right now, I'm actually the only surgeon in Canada who is able to offer this kind of approach. So again, it's an important contribution we're bringing also to this country in terms of a completely endoscopic approach for the management of atrial fibrillation. And this is an example of this very, I would call, obviously as a surgeon, elegant but also sophisticated approach, where we do not stop the heart, we do not open the heart. We use these specifically designed tools, these catheters that are able to navigate around the heart, on the outside of the heart, and then we are advancing the device that will be secured to the heart. And once the device is in place and safely and correctly positioned, we are then able to deliver a energy, which means we're able to create some lesions, some ablations. The ablation could be considered like a sort of barrier, like a wall. If we go back to the definition of atrial fibrillation as a irregular electrical storm, the idea of the ablation is to restore a normal rhythm by creating barriers that can help the electrical activity to become more organized. And I'm actually very proud to share that we performed the first minimal invasive MACE procedure in Ontario. As Dr. Manson was mentioning, I joined St. Michael's in January, and this procedure has been performed a month ago. So we are already really continuing to bring innovation from this standpoint. And my final overview of the innovations is related to minimal invasive coronary surgery. We actually have two very established techniques already in the field, which are obviously bypass surgery or stents. Stents are used in a very good percentage of patients, and they work extremely well. They're obviously very limited in terms of how invasive this approach is. As you know, it's just a puncture down through the groin, or nowadays even through the wrist. And then there is coronary surgery for those patients who have more advanced and complex disease. But historically, coronary surgery has been performed by making a huge incision on the front of the chest. It is actually now possible to perform such procedure in a less invasive way, and we can actually use a platform. It's a robotic platform, which I hope the audience can see here. Actually, it is named after Da Vinci. So it's actually a nice coincidence that I'm sharing this exactly while we are celebrating our genius in research. So the Da Vinci robotic platform is a platform that allows us to is allowing to perform the procedure as you can see here, by having a very less invasive approach. So for those of you who are viewing this video, I'm not even actually at the bedside. I'm actually on the corner in the black, because you are not directly operating on the patient. The robot is controlled by the surgeon, but the surgeon is actually nearby. So you're controlling this very sophisticated piece of equipment. As you can see here, I'm moving the hands of the robot, and is extremely precise and detailed. And actually the vision you can have, it's not possible to appreciate through this video, but the vision the surgeon has is a three-dimensional vision. So it's pretty impressive in the quality of work that can be provided. So that's the end of this overview of really this pretty incredible advances that we're able to offer now beyond what is normally a cardiac surgery, which is considered to be invasive, but it's no longer the case. I also have created a website where for those who are interested, they can find further information work, but I also share what has been happening, and I also have different social media channel for which this is again just to keep people up to date with such advances. And this is my overview of our innovations in cardiac surgery.
Thank you, Professor. This is mind-boggling, especially for somebody who doesn't work in the medical field. It's really a step forward. It's almost, it does sound like science fiction. And I'm actually very glad that the Italian research started in this field and is developing so fast, and it's also being brought and exported abroad. Now, I would like to ask you a question. First of all, I would like to mention that people that are viewers are able to, at the end of the presentation, in a few minutes, I have one last question for Professor Bisleri, but they're able to ask him questions. If you want to do so, please click on the Q&A tab on your screen, and we will be able to relay your questions to Professor Bisleri. But let me pose you one final question. Given your fantastic and broad experience and career, both national and internationally, what, in your opinion, are the main differences or approaches that you noticed in the field between Italy and in Canada?
Well, I have to say that we have obviously two very different systems. From my angle, obviously, as a physician, so in healthcare, I have to say that in general, there are regulatory issues which are different between the two environments, the two worlds, and not necessarily Italy, but I would say more the European Union and North America, thereby, Canada or US. And it may sound like a paradox, but most of the technologies that I presented are often actually developed here in North America and US many times, but also in Canada. But they are not clinically used first here. And this is because historically there has been sort of more difficulties with the regulatory bodies, and the approval has typically been more streamlined in Europe with the so-called CE mark. So that had actually helped having most of the innovations, which I'm glad obviously you're being positively surprised about seeing all these technologies, which really nowadays are reality, are no longer science fiction, but are like daily reality, have been used for many years in Europe and in Italy, way before they actually landed here in North America. I think that maybe now the landscape is slowly and slightly changed in the way that there are still some regulatory differences, but in general, technologies are coming, I would say maybe especially in Canada, without Canada, somehow in between Europe and US. I have to say that the historical approach that maybe we have had also in Italy has been to really be early adopters. So most of the key opinion leaders continue to be in Italy, and I hope that the landscape that we are facing nowadays, with financially and generally, will actually allow to continue to provide enough funding for the healthcare system in Italy, so that this will continue to be a possibility. I mean, it would be otherwise a pity with so much talent. And I mean, as I said, I'm the typical example of a series of technologies, technique, and expertise that have been really exported here and wasn't present. And I'm actually doing very pioneering work now here, thanks to the background that was built there. So hopefully we'll continue to be like this reciprocal exchange.
Right. Thank you. Question. You said you operate with that amazing robotic machine called Leonardo. Sorry, excuse my ignorance. Is that a machine is produced in Italy, or is that US technology?
No, well, unfortunately, I have to say that 99% of what you've seen, it's not, it's not done in Italy or in Europe, but in US. Mm-hmm. I have to say, interestingly enough, many names are actually Italian, because for many reasons, but no, and that's another thing. I mean, the possibilities of I have to say, if I can bring another example, in cardiac surgery, actually, one of the I alluded to that. There is one device we use. Regardless of minimally invasive procedures, 90+% of our heart procedures, open heart procedures, are done using the so-called heart-lung machine. Yeah. And interestingly, the heart-lung machine had really one of the main places where the pieces were built in Italy. in Mirandola. So where again, Pico della Mirandola was from. So, and now because of, again, changes and because of the earthquake that occurred some years ago, things have started to shift. But that's another example how Italy has really represented a very important, if not critical, core piece of this, technological, and hopefully there will be chances again in the future.
Right. Question. What actually struck me was that most of the procedure you use and you implement are without anesthesia. That means, which is actually, I'm sure it's absolutely more efficient. Recovery time is probably much, much easier, and it's less dangerous. So I just wanted to clarify, you talked about arrhythmia and how you cure an atrial fibrillation, and you said you could do that without anesthesia, as well as some aortic procedures. If I'm not mistaken, you also said you can operate with on a beating heart and also without anesthesia. But you also mentioned the stent procedures, or what we call, I guess it's not a bypass procedure. Are also those implemented? Do you also operate while posing a stent without anesthesia on the patient?
Yeah, so first of all, maybe one thing that is important to stress is that one of the most exciting evolution in the field is that cardiac surgery has been, not only has been, like a relatively new specialty. If you think that at the beginning of the 20th century, it was initially thought it was impossible to operate on the heart because you had to stop the heart. And actually the first procedures that were performed were roughly in the 50s. Nice. So it's only 60 years old, so not that old compared to many other surgical procedures. But then it really underwent a lot of changes. And then one other specialty that actually branched off cardiology, which is called interventional cardiology, started to emerge quite significantly. So stents, for example, that you alluded, are not done by a cardiac surgeon, by a cardiologist. But all the other procedures that I presented are actually now done through what we call a heart team approach, which means that a surgeon and the interventional cardiologist are present. And I have to say, from that standpoint, this is actually something where I hope that back in Italy, this could actually be implemented, because here as surgeons, we are very much involved in these technologies. Whereas in Italy, it's a bit more of a different situation where they're like two separate words. And that's actually an important aspect to implement. Many procedures can be performed without anesthesia, stents, for example, some transcatheter ablations for atrial fibrillation, again, puncturing the groin. Some procedures, you correctly said, the one on the TAVI, the one using the aortic valve using a catheter, yes. However, most of the surgical procedures are performed still with a patient asleep and intubated. Right. We are moving towards what we call fast track protocols, which means that patients can be woken up and extubated at the end of the procedure, but still for many of those are requiring intubation.
Right. I have a question from one of our viewers. Anna is asking, do physicians cooperate with engineers and bioengineers to develop these robots that actually perform the operations, and how?
That's actually, thanks, Anna. It's actually an excellent question. And yes, that's absolutely critical. You've got to remember that most of the times, and this is not just medicine, but in any change, any implementation, you can have the top down or the other way around. So this is not something where somebody in a remote lab is just coming up with some ideas that can be translated to practice. It's really a two-way process where our interaction with the engineering counterpart is extremely important and relevant. I have to disclose that my other big passion is actually engineering. I was when I was choosing between my master degree, I was like either choosing medicine or engineering. So I actually collaborate, like personally, I collaborate a lot. I have myself patented instruments, and I'm continuing this collaboration, which is extremely fascinating to see where we're getting. And now we are obviously using also AI, so artificial intelligence, often to deal with data and interpretation of different conditions. We are using more sophisticated engineering capabilities to even merge different information. When patients are undergoing tests, medical tests, we can actually, we call sometimes fusion imaging. That means we are putting together different pieces, and we are provided with a final image, which is not really nothing from each of them, but the result of the sum of all of those. And then obviously trying to implement this with obviously engineering and advances. I'm again very proud to say that, for example, here at St. Michael's, we are now working together. We have just recruited a neurosurgeon who's been a pioneer in remote navigation, and we wanted to hopefully extend that to cardiac applications, where there's going to be the idea of very advanced, again, navigation using certain joysticks and dedicated consoles that we can do operations even less invasive, but also remotely. So we could be in our, maybe not office, but in a certain room and operate from far away.
Fantastic. Professor Bisleri, we have a ton of questions that just came in. I don't know, can you see them, or shall I read?
I can, if you're okay, I can start going through those. So I can see here, all people that have atrial fibrillation need an operation or not. So again, I hope I didn't give people the wrong impression that any kind of heart disease requires an intervention. So the answer is absolutely no. Please, this was just an overview of the possibilities that we have available, the tools that we have available. So to answer the question, if you have atrial fibrillation, you first need to be seen by a cardiologist. And we have guidelines in medicine that are suggesting what is the best option for patients. So many times medications are the best option. Some other times a treatment using a catheter is the best. And some other times what I show you is the best. So you really have to rely to your cardiologist or practitioner, and you're obviously more than welcome, if you want a second opinion, also to get in touch with me. But do not think immediately of particular interventions. And with respect to heart failure, yes, to respond to the question from Dolores, there are definitely options for heart failure. This is actually another extremely exciting area. You've covered very well my past experience, but I actually also spent time in the US, not only in New York, but also the University of Pittsburgh, where in 2001, I actually had the opportunity to see groundbreaking work on the new artificial heart model. So that's another exciting area where, to answer the question by Dolores, there are many devices that are really changing the impact, because unfortunately, heart transplant is at the same time the best possible option for patients, but it is not so widely possible and available. And now the technological advances that we have in heart failure are actually making these important alternatives, sometimes as a bridge to the transplant. So helping patients to be able to wait until a transplant is becoming becoming available. How does so is someone record? For those who are interested in contacting, obviously, if they want information, they can they can find easily through on Google. They can find information about my office if they want to have further clarification about surgical options. So I hope that will answer the question. And there is one about Vanda. That's a very important question about how one qualifies for minimally invasive cardiac surgery. So unfortunately, not everyone is fit for these kind of procedures. So it really comes down to the judgment that is done based on a series of assessments. So we need to have many pieces in the puzzle, having different tests being performed. And I also want to stress something that is very important. We don't have to compromise the safety of a procedure for a potential just a smaller scar. So as much as I'm very much invested in even in my profession to do as many procedures as I can in a less invasive way, it's important to provide a safe procedure to patients. So the answer is simply that we need to assess on a case by case and then go from there. And the duration effect of minimally invasive surgery, the same as classical surgery, that's a very important question by Patricia. The answer, absolutely. If we are not able to provide the same efficacy and durability, this actually links to another question. When I see many patients asking, for example, can I have the aortic valve done using the transcatheter one or the clip for the mitral? Well, these are very exciting opportunities that we can offer to patients, but they don't have the same durability as surgery. So again, we need to tailor the best treatment based on the patient conditions. And at the same time, if we can, and I said many times we can also try to avoid the trauma to patients by having less invasive approaches.
Fantastic. If there's any other questions? No? Well, Professor Bisleri, I thank you very much. This was quite an eye-opener for people that are not in medical field. And you're right, we're very proud that both Italian, Canadian, and international research have brought us to this point. Now, I do actually have a last questions. Do you think, given the fact that it's robotic procedures, and we've seen also a picture, I think, of you are not even next to the patient, you are working with the machine. Do you see in the future the possibility even to operate in remote, when somebody is maybe even in another city or in another country?
Yes, that's exactly the work we are trying to do, which is actually trying to work on what is called remote work that is going to be performed. It is actually extremely critical to have different pieces. One of the, and I don't want to enter a very maybe debatable topic, but you need to have an infrastructure to support, like 5G is a technology that can help having a fast, data transmission enough so that we can potentially remote control devices and technologies, allowing for potentially these kind of procedures. I can tell you that we already have not to perform procedures, but to actually proctor people. We already have tools available, and it's actually quite impressive to see that it is possible, for example, for me to sit in my office and having a surgeon even in another country doing a surgery minimal invasive, and I can see what's happening on their screen, and I can actually point out saying, don't go there, actually pay attention to these other, and trying to guide the people from that standpoint. So it is actually almost possible even right now, but for sure the technologies that we are working towards are going to facilitate this even further.
Thank you. Oh, I'm sorry, there's another question that just popped up right now from Iris. Thank you, Dr. Bisleri. Do we need to have a referral from the family doctor in order to be able to see you?
Yes, so for these technical questions, I would definitely suggest to reach out again to my office, and they will be able to provide you with all the necessary information. Yes.
Okay. Well, I would like to thank you for your really interesting, insightful presentation. I would like to thank the Consulate General for participating. And really thank you, Dr. Bisleri, for celebrating the Day of Italian Research in the world and for celebrating Leonardo da Vinci's birthday, which happened about 600 years ago.
I know, really, thanks again. For me, as I said before, it's a real privilege and honor being here today. So thanks to you, the Istituto Italiano Cultura, and thanks to the Consul, obviously, for the privilege of the invitation.
And thank you very much for participating in this panel. Arrivederci. Grazie.
Arrivederci.